2.
Yep. John, everyone seems to be attentive in your, oh, one more question?
Is that the third question? Yeah, that's it.
That's
right?
it.
Yeah.
Okay. Thank you, Mark. Mark.
Okay. Those are John's questions. Anyways, that's fine.
Yeah, let's do Mark's question.
So one of them is, I think, not multiple choice, but anyways. Okay. It's a lot of movement.
Where we separate the, what happened?
I think the last question is not multiple choice, but I guess we can't respond to those if they're not multiple choice? Okay. It can be anything that you think is relevant. Twenty more seconds. Five seconds. Good. Okay, great. Okay, so are we up? Okay, so I was asked to talk about this topic, which is a good topic to discuss earlier in your career because there are a lot of nuances associated with this and some apprehensiveness if you've not done them when you were a fellow and just watched them for the most part. So we thought this would be a great topic to discuss. So before we start, I wanted to show you a little clip from a movie. And it's really about what Eric's mentioned about this course, is that we want it to be, you know, an intimate discussion, feel safe in our environment here. You know, when you start your career, you're a little confused. When you get out there, and a lot of things coming at you, and you got to figure things out. So I thought this was kind of apropos. So if you can just turn up the volume. Turn it up.
Frank, this is a safe place. It's a place where we can feel free sharing our feelings. Think of my office as a nest in a tree of trust and understanding. We can say anything here.
Anything.
It's okay, honey. That's why we came.
Well, I guess deep down I'm feeling a little confused. I mean, suddenly you get married and you're supposed to be this entirely different guy. I don't feel different. I mean, take yesterday for example. We were out at the Olive Garden for dinner, which was lovely, and I happened to look over at a certain point during the meal and see a waitress taking an order, and I found myself wondering what color her underpants might be, her panties. Odds are they're probably basic white cotton underpants. But I started thinking, well, maybe they're silk panties. Maybe it's a thong. Maybe it's something really cool that I don't even know about, you know. And I started feeling, what? What? I thought we were in the trust tree in the nest. Are we not?
We are.
Okay.
We are. It's okay. We are. It's okay. It's okay. Please, continue.
I don't know where I was going with that. I guess what I'm trying to say is that now that I'm married, I'm definitely feeling a little freaked out about the fact that I'm going to have sex with only one person for the rest of my life.
Okay. We'll keep going now. So, okay, so I will start with the talk. Why does an adult or pediatric interventional cardiologist need to know how to do this? Well, there are a number of reasons, and the obvious ones are your left-sided heart interventions, creating baffle fenestrations, and our EP colleagues sometimes need our assistance if they're not comfortable with certain techniques, especially in the congenital population, pulmonary venous obstruction interventions, which are rare, but obviously needing a transseptal puncture. There's no doubt this is a team approach like we talked about before. There's a lot of people involved, and you have to really depend on all your imaging specialists. And that's a good thing, actually, because it is a team game. But ultimately, it's going to lay in your hands, and you're going to have the proper visual spatial orientation. You're going to need to be familiar with some of these advanced imaging techniques that John had mentioned that are coming probably to your Cath Lab at some point. And you're going to be able to have to navigate tough anatomy. So what's on your grocery list? Well, most Cath Labs, I think, still perform transseptals with TE guidance. ICE, if you're comfortable with, is something that a lot of patients can have procedures done without the need for TE. You're going to need a transseptal assembly. You're going to need your BRK needle. You're going to likely need an Agilis sheath, depending on how complex the anatomy is. And you're going to have to become familiar with RF, radio frequency, in tough to get through anatomy. I'm not sure if you use that in your lab. In our lab, we do have RF, but we don't routinely use it, I would say. You're also going to have to be familiar with which wires you're going to have to use if you can't get across, whether that being coronary wires, the in-away wire. You're going to have to be familiar with dilators that are going to potentially help you to get across in tough anatomy as well. And of course, balloons, which we use also to pretty much dilate almost every septum if we're using them for big interventions. So we use coronary balloons and we use peripheral balloons like the Mustang balloon, which comes in different sizes, 6 millimeter, 8 millimeter. Sometimes you may need to use a Z-Med balloon even to dilate the septum. So you have to be familiar with these, and they have to be in your lab. Really, you don't want to be running down to interventional radiology to find a balloon, so you should know your grocery list. And you need to know your lengths and your widths. It's very important with all this equipment. Okay, I know it's there's a lot of equipment to memorize, but it's so important when you're doing a case that you're not guessing what lengths and sizes and widths things are. You know them; they're at the back of your head. So, as I kind of asked you a question about before, and I think most of you got this, was your transseptal assembly, which is typically most people, I assume in this lab, would use the typical SRO or SLO. dilator, and then your BRK or BRK1 needle. But you really need to know the lengths of them, and that's important because when you're actually introducing your equipment, you have to know the length so that you don't inadvertently puncture somewhere else where you're not meaning to puncture. We would typically put a 3cc syringe at the end of the needle, and so we give it a little puff to make sure that we know our needle's still in the dilator before we engage the septum. But like I said, the measurements are there, 71, 67, and 63 respectively for your needle dilator and sheath. The other option is the Agilis sheath, which I like actually personally because it's deflectable. The issue with that is you need to know that it's 71 centimeter usable, but it's 91 centimeters in total. So you're going to need a longer needle if you're going to use the Agilis sheath to use for your transseptal. Okay, so that's something to be aware of. You're going to need the longer BRK needle, and so. This is just an image that engaging the septum here with our this is actually using Agilis. So there are some nuances. So when you look at this chest X-ray, I mean that's a bit scary in terms of doing a transseptal. You're looking at the patient has scoliosis. The heart is rotated and it's extremely on the left side of the heart, left side of the thorax, and so those are issues you need to deal with before the patient comes on the table. So in this case, I would say you have to consider: you're probably going to have to make a curve on your needle. You may want to use Agilis as your first step instead of the BRK. And so just looking at severely enlarged left atriums, you may want to consider a slightly more inferior puncture and a slightly more rotation on your needle. If it's enlarged right atrium, again, the Agilis sheath would be very helpful. If you have a resistant septum, it's very thick. For instance, I would probably go right away with your RF needle. Okay, I wouldn't even play around with the BRK. I don't see a reason to tell you the truth. And again, if you know what you're going to do, the procedure itself, hopefully, you have to know where to puncture. So again, if you're doing a medial paravalvular leak or a mitral clip procedure, you want to be a little high and posterior. If you're doing, for instance, a Watchman device or an ACP, you want to be inferior and posterior and inferior. So, certain ones you don't have to worry about. I think if you're doing a balloon mitral valvuloplasty, you can go anywhere in the septum, right? But with these large devices, large delivery systems, you really have to have a good target, okay? And you have to stick to it, all right? You have to be patient, okay? Because it will mess up the rest of your procedure if you're not in the right spot. And of course, take a history. This patient has a huge baffle leak, so I mean, you don't really need to puncture anywhere. You can just go through the baffle. Some of my older esteemed colleagues, I don't have the experience of the faculty here, but they may have been the day when you used to do transseptal just with fluoro. I suspect few of them have, right? As someone who trained with ultrasound, I would feel very uncomfortable doing this. So I would not recommend this if you trained in I don't know, the 90s, 2000s, the 2000s, I guess. Huh? But so, I mean, you're going to use either TE or ICE, and as John had mentioned, there's a lot of very interesting multimodality imaging which will hopefully come into play and will be easy to use. I think that's another issue. But these are the three main views that you're going to need if you're going to do it. If you're doing it by TE or if you're doing it by ICE. With ICE, you really have to get comfortable. With TE, it's obviously your echocardiographer can give you these images pretty easily. But really, if you want target practice, you have to go into a bicaval, you have to go into a short axis view, and you have to go into the 3 or 4 chamber view. And you will then be able to precisely locate where you want to be on the septum, okay? If you're using ultrasound only, okay? And just looking at these views here, so you can see we're engaging the septum in the bicaval and the short axis. And then you can also see us in the 4-chamber or the 3-chamber modified. You can see the height. There's a patient with a bioprosthetic mitral valve planning to do a mitral valve and valve intervention. And so with these 3 views, we were able to puncture where we wanted to. So be patient. Ask your echocardiographer to get you these images. Get those 3 images before you puncture the septum. In specific cases that you need to target your anatomy. When T is not good enough. So T sometimes it's not good enough. Sometimes when it's very calcified septum, so somebody's had 3 operations, for instance, and the septum here was measured at 0.5. To tell you the truth, I thought it was like 5 centimeters when I was trying to puncture through it. But we had to use ice, and I said, move the T probe away. First of all, make sure you move it away because you get a lot of interference. But we could not see tenting at all. I didn't know where I was. So the ice was very helpful because of the more near-field visualization, and we were able to safely puncture across the septum, and we were able to see tenting. I wasn't able to show you the tenting, but in this case, it did help us a lot. I just didn't save that slide, the image rather. And you can see us tenting the septum on fluoro here. The nice thing also is that, if you have a bioprosthetic or an aortic valve, you can also use all your imaging to your advantage. So if you see a bioprosthetic aortic valve, like if you're above it, well, you're probably not in the right spot, right? So if they have that, use that to your advantage. You forget about these things when you're doing the case. You're so focused on the septum and the ultrasound, right? So you have to be looking at multiple things at the same time. And of course, we balloon the septum. And actually, you can see the waist still on our balloon there. So this was a very tough septum to dilate. So in terms of your ICE catheter, I'm not sure how many of you use ICE, but it is 8 to 10 French, and it's a beautiful thing because it does steer quadridirectional, and it does give you color flow and Doppler capability. So we do really like ICE, and these are the advantages that most of you actually said, which was essentially you avoid TE, no general anesthesia. You learn something new, and it's going to become more important in your practice. You don't have to clear the GI tract, which is important, and you do get better visualization of the inferior septum. Well, that's very important too. If you're not able to see the inferior septum on TE, pull out the ICE probe if you need to see it. And if you put your ICE probe in the right atrium and different images, you can see the long axis, you can see the short axis, and you can see the coronary sinus, you can see the mitral valve, you get a lot of great images from ICE. So it just takes a lot of practice, and a lot of these are very subtle movements, okay? A little rotation goes a long way. You rotate just a little bit here and there, you can see different parts of the septum. This happens to be a patient with an ASD, but I'm just trying to show you the ICE images, obviously. But if you just do slight rotation, you can see the inferior septum, you can see the superior septum, you can see the aortic septum, the aortic rim. So it's a question of just getting comfortable with it. And beyond echo, well, if you're going to do a transseptal puncture, of course, John elucidated to this in his talk, but there's going to be a number of technologies coming down the pathway. This is holographic imaging that John had mentioned briefly. This is actually Eric and I don't know if we were testing this out or what, but we've been testing out the holographic imaging with a company, and we're going to see if it helps us with procedures. I'm not sure if it's going to help us or how much it's going to help us, but we're going to be evaluating it, and hopefully next year we'll have some information for you about how it helped us with these types of procedures, specifically structural procedures. And John, I'm not going to show this slide again, but John had already mentioned the multimodality imaging that he's been working with, and how 3D images overlay with fluoroscopic to give you beautiful localization of the septum in your transseptal puncture. So in congenital heart disease, mind you, the standard rules do not apply. Okay, these bicable views and short axis views and 4-chamber views are not quite as useful when the heart is not where it should be. So I did want to just briefly talk about 2 potential issues you may be asked to deal with, which is patients with a Fontan and patients with a previous baffle, and that you may need to you may be asked to puncture these as well if you're an adult interventional cardiologist. Typically, nowadays, we see lateral tunnel Fontans and extracardiac Fontans, and these are most of the cases that we've been asked to help with transseptal punctures rather than RA to PA Fontans. And we would typically do a CT scan and understand the anatomy prior to doing any type of procedure. And you can see here the Fontan anatomy in A and B, and then also the baffle anatomy in the C image. So that's a lateral tunnel Fontan, an extracardiac Fontan, and a mustard. And you can see the tissue that they're made of, all autologous pericardium and PTFE. Another potential issue when 2D fluoro and ice is just not good enough. And this is a patient who, and I borrowed this slide from Lee, who they needed to get to the left side of the heart, so they went from the left pulmonary artery. So that may be something that you may be asked with in your career. And so this was essentially a transseptal from the LPA. So if you have no access from below, you need to consider access from above, right? And this is a system made by Baylis, and essentially it's an IJ transseptal solution. And again, it's 8.5 French. It's a steerable sheath, and they essentially use, they have a wire which also acts as a pigtail for you, so you don't have to exchange your wire. And I actually think it's quite a nice ensemble if you have to go IJ. We did test this out as well, and it actually works quite nicely if you need it. And this is the wire that you would actually puncture with. It's an RF solution, and again, it's a pigtail wire, so you don't have to exchange things. So just to show you a couple cases, this is a lateral tunnel Fontan transseptal puncture with ice. So again, we initially started doing these procedures with TE, but then we use ice instead now because it's much better for the patient again. And you can see, as long as you get good visualization of the lateral tunnel Fontan, puncturing should not be an issue. That being said, you can see how thick and calcified this is as well, and difficult to appreciate you tenting. Here we had a difficult time crossing, eventually had to use a coronary wire and coronary balloon because it was so difficult to cross. So make sure you have some coronary wires in your cath lab, especially for the pediatric labs. And we would typically just use a Pro Water or Wisdom wire, which is a very standard coronary wire. And then we dilated more with a peripheral balloon and an Inouye wire, which we like because of the curve that the Inouye has. And of course, fluoro's your friend. Confirm that you're in the right position. Okay, nothing wrong with an angio. And then just showing you a case of D-Transposition. So, on the left, you can see the basic anatomy. There's a systemic venous atrium, the superior baffle, and inferior baffle. So in this view, it's really kind of difficult to tell whether you're in the right plane, right? I mean, the image, you think it's pointing at you, you think you're going anterior. So you really need to do a lateral, right? And the lateral will tell you if you're pointing anterior, right? If you have biplane, then that's fantastic. We don't have a biplane, unfortunately, but we're getting one soon. And then again here, you can see us crossing the septum, crossing the baffle, and what you can see there is actually we're injecting bubbles, so we're comfortable that we're across. And then again, we use a standard. We would balloon it with whatever balloon gets across. So we usually use a Mustang balloon as our standard because that typically will get across. If it doesn't, then again, you'll have to use maybe a coronary balloon and a coronary wire to get across and dilate the septum. I think it's very important, especially if you're doing large access. And then again, confirmation, just that you're in. Sorry, I missed that, but just that you're on the right side of things. This is a technique that I read about that yeah, we're almost done. Two slides. And if you ever find you're having real difficult time crossing, then you can try a snare to keep you secure in the septum. We've not done that. I'm not sure I would necessarily recommend it. So in summary, know your equipment and your anatomy for targeted site procedures, and be patient, of course. The Fontan punctures and baffle punctures are not common, but you may be asked to do them if you are an ACHD center. I'll leave it at that.
Thank you, Mark.
Thanks.
I don't know, but other polling questions?